Yes, lots of questions have been asked in TMD. Yes, recently also in the exam, and it has always been a very, very hot topic, and we have covered that in our hot notes. Hannah, I'm not sure if you have checked or you've not reached that weekly plan yet, maybe, but we have a lot of important Australian Dental Journal TMJ articles, which cover all the TMDs, MPDS, joint derangements, far more than Odell case. Like earlier, only Odell case was important. It would be in oral medicine, so probably you're far away from that week's plan right now. So it will come eventually when you move on, and you will have the TMD articles, the surgical management, the non-surgical management. So we have covered it entirely, and the ADC examination questions which come on the TMD, what kinds of splints you will be using, what kinds of splints to be advised, hard versus soft splint, Michigan splint, then advanced mandibular advancement splint, and then for sleep apnea. So for individual problems, what kind of splint is given, I've covered. We have talked about that. The references has been shared. So TMD is extremely important. Entire SBQs get asked on that. And the what are the indications where you would use a particular kind of splint, all is covered. And what should be the sequencing when you're planning the treatment plan for such patients. So whether it's for bruxism, for sleep apnea, or for your patients with disc derangements, there are different splints indicated for different situations. Although today, in today's class, we are not discussing bruxism. So know that TMD gets covered and TMD gets talked more when you're doing bruxism chapter, right? So probably in the upcoming week, I'll take the bruxism chapter as well. Yes, exactly, Nikita. So your third edition TG has given on just one page on trismus so far. Is that correct? Everyone's aware of that, right? Your existing third edition TG only gives just one page, one chapter, or one page for the trismus chapter. I'm going to show you that in a second. Just wait a moment. So in eTG updates, it is covered in about 3 or 4 pages. So that is why I wanted to take this chapter, because this is already getting asked in exam. Those questions are already getting asked in exam. So I thought, why not do the expanded version for this examination preparation, right? Isn't that a good approach? If you're doing an expanded, updated version, so we don't need the TG 4th edition basically. And we don't need ADCs to say what edition is coming. Trismus anyways is an extremely important exam topic, and if we have an expanded version of it coming from the eTG, so we know it's a very valid, authentic, legitimate Australian reference, and this chapter is anyways extremely important, already part of therapeutic guidelines, so why not prepare it in an expanded and updated version? Is that right? Everyone agrees with me, right? Priyanka, that is where the confusion is. So again, let me remind you, splints are for TMD. So bruxism, sleep apnea, MPDS, right? Or your disc derangements, they would be managed by splints. Agreed, Priyanka? Today we are talking about is trismus. Differentiate between these two very specific topics. Bruxism is grinding of the teeth, parafunctional habit, leads to MPDS, myofascial pain dysfunction syndrome, right? Which is a TMD, temporomandibular disorder involving the muscles. Whereas the disc derangement is a joint specific joint problem, TMJ, right? TM joint disorder, right? Yes, I have my tea as well. So grab your coffee or tea as well. So is everyone aware, up and alert that bruxism and splints are a separate topic, TMD separate topic. Trismus is limited opening of mouth is a separate topic. So let's just bring awareness and have that perspective of these are two very distinct topics. I'm talking about trismus today. And yes, now that I have seen the confusion, we'll soon, next week probably, we'll do bruxism also. Right, Priyanka? So now in the 2 weeks only, you would have learned both the concepts and would have learned the contrast. Okay? So probably because I gave you in the poll to choose between the two. So yes, let's do this week our trismus, and the next week we'll do the bruxism also. And hopefully if I can do something in TMD, because bruxism again is just one part of TMD. If you take a look at TMD, the disc derangements are part of it. Bruxism is part of it, right? Then MPDS on its own is entirely 50% of TMD, MPDS, which involves the muscle, and then what involves the joint is total together. That's an umbrella term of TMD, right? So that will become a huge topic, but I can take bruxism in one class and then we can go on MPDS and disc derangements. Okay? So probably 2 more classes for that. But next week we'll start with bruxism. And internally in our program also, Priyanka, you would find the TMJ classes. They will come in our oral medicine week. So do not worry, in the hot notes also and in the classes also, you have beautiful MPDS classes, beautiful TMJ disorder classes waiting for you right there. So you can come, go there, watch and learn. Okay, already done. If you've already done, then don't worry. Next week, when I take bruxism, I will cover it more. Yes, TMD in depth also is getting asked in exam, Nikita. That's you, right? So your name got up. Yeah, Nikita. So TMD, although it's a specialist management, but as a general dentist, knowing and understanding it is really important, and it's getting asked in exam a lot. Okay. So is everyone ready to learn about trismus with me? So let's just see what original third edition had in store for you. Thank you, Henna. That is what I really want to do at Winspert is I want to take you beyond your undergrad education system. I know even in the college days you struggled so much with so many concepts, but I have to make sure that I send you to the ADC examination with 100% preparation of each and every hot topic. So what I have done in the last whole year is I have understood, studied the syllabus, studied what gets asked in exam by studying a pattern in MMF, Mega Master File, Ultimate Advanced File, and Ultimate Advanced File 2. What I found on studying the pattern was there were some repeat concepts, which we coined the term hot topics, which were repeatedly getting asked in exam. Although the questions, even if they were coming new, but the hot topics were same. So by studying and classifying those hot topics with each subject, we collected the list of the hot topics and started creating content, material, and notes on those topics from varied Australian sources. So what happens is you also prepare for the questions which have already getting asked in exam or which have already been asked in exam, but you also get prepared for what new may come in exam. Right? Is everybody getting the approach how we are preparing? Because you have been given the hot notes, everyone, right? For every subject, you have been given hot notes. And you know that I am adding to those hot notes every single time. Now, we did an important class last week, which was anxiety management in dentistry. I'm going to add the hot notes on that topic under your health promotion folder in a day or two. So this trismus, as you can see, in TG is just one page topic. Everybody, can you appreciate that? It's just one page topic. Only covers about the causes. That is it. The management is not covered, the complete assessment and diagnosis, information gathering part is not covered, management, diagnosis, treatment, evaluation, red flags, nothing is covered here. Can you all appreciate? Only the etiological factors are given, but nothing beyond that is given. Now with your eTG, there have been expanded information both about the TMD, which I'm going to cover, of course, in the coming classes, as well as trismus. So with trismus, basically it is completely expanded now. So overview, assessment, and even your management plan has been given now in the new TG. Can you all see that? So a lot of new information has been added, assessment part, management part as well, right? And the examination is giving you questions on these. So I think this would be a good opportunity to prepare a new chapter with all the expanded information. And you don't even have to subscribe to eTG. I've got it all covered, okay? Clear for everyone? Yes? So are you excited? Happy to learn today? All about trismus. So once we practice trismus, the topic and everything, we'll talk about the causes. We talk about the assessment, which is information gathering, how to assess your patients when they present with the trismus. Then what are the signs that you must be looking for, which would be red flags, which will immediately prompt you to send your patient to the specialist management. And then the management part, where you're, as a general dentist, what you can do. And based on the findings, your management will change as to which specialist to refer your patient to. Do you want to learn based on the findings? Because trismus can come from varied etiologies. Based on the etiologies, assessment by history taking, by signs and symptoms, by assessing red flags, then you will decide the management as per what is the cause and then what should be the management of that causing factor. Whether that requires active dental treatment or referral to any particular specialist, medical specialist, oral medicine, oral surgeon, ENT specialist, or whichever may be required. Understood? Everybody. So management plan will also be learned by knowing the underlying cause. So first, when I talk about the overview and the etiologies, please pay full attention because that ultimately decides and helps you think about the management plan. So first of all, how to define trismus so that in examination, nobody confuses it with bruxism, right? Nobody confuses it with your TMD. Is that clear? Trismus on its own is a separate entity. Bruxism is separate, right? The underlying reason for trismus, one of the cause could be TMJ disorder. That is precisely one of the reasons. So if there are 10 reasons which leads to trismus, only one of that is a TMJ disorder. So when you think of trismus, would you only think of TMD? Give me a big yes and no, because so far all that you have been thinking, when I say trismus, you think TMD. Isn't that right? Isn't that what's happening? I say trismus, you think TMD. That is exactly what you have to drop right here, right now. Old way of thinking. Now you hear trismus and you think there is an incorrect or insufficient mouth opening, and the underlying phenomena could be differential causes. So trismus only means inability to close the mouth, but there can be different phenomena causing this, and TMJ disorder is just one of those. Absolutely give me big yeses if it's so far making complete sense for everyone, because this is where your power lies to answer the questions correctly in examination when your concepts are crystal clear. Big yes. That is exactly the kind of yes I'm looking for here. Now, when your ability to open the mouth is measured, usually that question is also asked in exam. What is the method by which you will check that the patient's ability to open the mouth is restricted? It is by using your patient's finger, and 3-finger test is done. Anything which is less than 2-finger breadth, that is a measurement less than 20 mm. So anywhere, any patient who cannot fit 2 fingers, and the generally 2-finger breadth or lesser is seen, that is a very significantly reduced opening, right? So ideal opening is 40 mm. Would you please write down on your notes if you need to? Ideal opening should be 40 mm, and reduced opening is range from 20 mm to 40 mm. But it's this 20 mm or less that is significantly reduced opening. Clear for everyone? Optimum 40, 20 to 40 is reduced, and 20 or below is significantly reduced. Clear for everyone? Is that crystal clear for everyone? Right? Now, there can be various causes for your trismus, right? And two types, acute type as well as your chronic type. So the acute trismus, in where the duration have been less than 6 weeks, that this restricted mouth opening, Mubaraka, has been for less than 6 weeks. That is an acute trismus situation. And where the reduced and restricted mouth opening has persisted beyond 6 weeks, that would be called your chronic trismus. Is the type clear? Acute versus chronic. 6 weeks period. Will you memorize this one and remember it in exam? Patient will present you the history, how long it has been, the restriction in the mouth opening, and that will immediately give you first classification of the type, which is if it's less than 6 weeks, it's acute type. If it is more than 6 weeks, it is chronic type. Big yes again. These are all examination questions. I want you to know it by heart and right away. I don't want you to go later to these points. Memorize them right at this given point. Now, what are the causes of acute trismus? So, acute trismus, which is within the less than 6 weeks span, most importantly comes from your acute oral infections. And we have done that either pericoronitis, spreading odontogenic infections. Everybody, you've started reading TG every day. You're taking on the WhatsApp 5-question mini test on WhatsApp group. If you are enrolled with us, you remember, every single day you're reading TG pages and taking a mini test on therapeutic guidelines every single day on WhatsApp. Why are we giving you that test every single day? Because we want to make sure that every single page, every single paragraph, every single sentence, we make you practice at least 4 to 5 times before examination, so that in exam you master these concepts, and that's how you get maximum success in exam. So now tell me, spreading odontogenic infections. We have read that trismus is an important spreading sign with severe and systemic spread. Is that or is that not? Trismus is a sign of severity. Yes. And that requires hospitalization and active dental treatment and IV drugs, IV antibiotics. So any spreading odontogenic infection can also cause your trismus. Pericoronitis also can lead to trismus, and peritonsillar abscess, which is a complication of tonsillitis. So these are 3 types of infections. Can anyone name it on the chat? What are the 3 infections that lead to trismus? Pericoronitis, spreading odontogenic infections, and peritonsillar. Pericoronitis, peritonsillar abscess, and spreading odontogenic infections. Write down these 3 causes so you remember 3 kinds of oral infections can lead to this. Pericoronitis, spreading odontogenic infections, as well as your peritonsillar abscess. PSP, pericoronitis, spreading infection, and peritonsillar abscess, PSP. Will you remember these 3 acute infection causes? Big yeses. Memorize it right away. I'll send you off the class so that you remember the concepts right away. Then another causes, acute causes, is surgery, especially after your wisdom tooth removal. Hematoma following dental injection. Can anyone here tell me which is the most important LA technique which can most likely cause hematoma? Anyone? Anyone? If you have watched my 1000 classes, The winning edge classes, the basic classes, absolutely covered here. PSA, your maxillary PSA block has the highest risk of giving you hematoma. Okay? And then acute temporomandibular disorder. Acute temporomandibular disorder means acute joint condition. What can be acute joint condition? Acute closed lock. What is acute closed lock? Can anyone tell? Acute closed lock? That the patient is unable to open the mouth because disc has come outside the condyle. So condyle is stuck and you're unable to open the mouth. Closed lock means mouth is locked in closed position. Is that correct? Closed mouth means mouth is locked in closed position. If mouth is locked in closed position, that means you cannot open. If you cannot open, that means it is trismus. And in acute joint situation, when can that happen? When the disc gets stuck in front of the condyle. Closed locks are because of internal derangement where the disc from the joint is displaced and comes ahead of the condyle between the glenoid fossa and the condyle. Now, why it is acute? Because it is sudden onset. Sudden onset, and it will give sudden pain to the TMJs. Acute pain will also happen to the patient. Now, whereas the chronic closed lock is a chronic trismus where the patient has a chronic non-reducing risk. That means if it's the first time, accidental opening and leading to a closed lock, accidental slip of the disc, first time, it will be acute because the time period is significant here. But if it has become repeatedly chronically non-reducing disc derangement, then it will be called chronic trismus-related chronic closed lock. Simple. That means the underlying phenomena is same. Acute closed lock, chronic closed lock, underlying mechanism of disc getting displaced is same. But only difference is acute has only happened in the last 6 weeks for the first time, whereas the chronic now it has been a prolonged repeated situation happening more than 6 weeks period. Do I make sense? Chronic closed lock versus acute closed lock. Underlying mechanism of disc displacement and non-reduction of the disc. Non-reduction means the disc is not reducing back to its original position. It is getting stuck ahead of the condyle. So that means both acute and chronic closed lock has the same mechanism. The difference is only the time duration. Understood? Acute one will have severe acute pain. Chronic one, usually the patient would have been adapted and the pain would be more dull type rather than a severe pain. Please give me yeses so I know that you're getting the concepts. I know you want to be in the trance and keep on absorbing, but give me yes and no so that I know. Yes, yes, Priyanka. So for your disc derangements, we use morning repositioning splints. And for MPDS, muscle disorders, and bruxism, we use Michigan. Beautiful, Priyanka. You have been doing your work really well. Everybody, beautiful Niharika. So Michigan for muscles, MPDS, bruxism, and mandibular anterior repositioning splint for your disc derangements. And advancement, mandibular advancement is for your sleep apnea. One is anterior repositioning. That's for MPDS, Priyanka. When I say advancement, that's for sleep apnea. Yes? Clear for everyone? Yes, Pooja? Okay, great. Now another acute cause will be stroke. So immediately stroke can also lead to that. Tetanus. Tetanus is also an acute condition. So these are your acute causes: infection, surgery, hematoma, acute joint problem, which is acute closed lock, and stroke and tetanus. Clear for everyone? Acute causes are clear for everyone or not? right? So odontogenic infections, which are peritonsillar abscesses, pericoronitis, these three acute infections, surgery, hematoma, acute closed lock, stroke, and tetanus. These are your acute causes. You want to take notes? Immediately take notes. Okay, you will be provided hot notes on this one also by next Monday or Tuesday. Even on Trismus, the hot notes will be published. Okay, so anxiety management will be published by maybe by the weekend, and the Trismus one will be uploaded by next Tuesday or Wednesday. Okay, so if you don't want to take notes, don't take notes. Don't waste your time taking notes. Try to learn and understand now, and hot notes will be provided. Now, what are the causes of chronic reasons of trismus? So more than 6 weeks is your chronic TM joint disorder, which is your chronic closed lock, I explained to you, and then your TM joint osteoarthritis. That is also a chronic reason, a chronic condition. Then congenital disorders. Congenital disorders include ankylosis of joint, coronoid hyperplasia, and congenital hypomobility of mandible. These are your congenital defects: ankylosis, coronoid hyperplasia, and congenital hypomobility of mandible. Other than that, you can also have oral submucous fibrosis, which is associated with your betel nut chewing. It can lead to OSMF, oral submucous fibrosis. Now, autoimmune conditions, yes, we are coming to that also. Priyanka, coming to that as well. So your connective tissue diseases are rheumatic arthritis and scleroderma. And even your systemic sclerosis, they are all your connective tissue disorders? Yes or no? Systemic sclerosis, scleroderma, and rheumatoid arthritis. And then tumors in head and neck. So either directly it could be effect of a tumor, or it could be effect of radiotherapy treatment, because even after radiotherapy, your patient can have progressive trismus. So sometimes a tumor is a direct cause, and sometimes it would be the radiotherapy. I will now in a while also talk about when you're assessing your patients and there has been history of radiotherapy and you see that your trismus is progressing, you will also have to pay attention to the fact, is the tumor coming back or is it just the radiotherapy, Ramona? Is that right or wrong? Everybody tell me, lights up a bulb in your head or not? After radiotherapy, if your trismus is progressing, should it not raise alerts and alarms that we have to check whether the tumor is coming back and causing the trismus if it's head and neck tumor? So it's either the tumor coming back or it is the effect of radiotherapy. As a dentist, as a healthcare provider, you would be on lookout for both or not? Tell me. Tell me yes or no's as a possible assessment factor. That is why information gathering cluster will have very important questions from this topic. Etiology is understood. Underlying etiologies, underlying differential diagnoses are understood or not? So that means trismus is a kind of a symptom or a sign, and based on the history taking, based on the assessment, you would define the underlying diagnosis. Isn't that right? What is the causative diagnostic factor? Right? So it will also help you diagnose some of the underlying conditions. True or not? Yes or no? Trismus is an important symptom and sign, and it would be helping you to reach an underlying diagnosis and make a correct diagnosis. Now, just knowing trismus will not inform you whether it's what is the underlying diagnosis. Is that right, Samina? Tell me. Just by knowing that it's a trismus, can you tell that what is the underlying cause? No, we cannot, right? So we cannot know that just by assessing the trismus, what is the underlying cause. That is why we need to do assessment of trismus, right? Coronoid hyperplasia is a congenital disorder where your coronoid processes excessively or increases in size. When this is increases in size, surgical management would be required, Priyanka, right? And when your condylar ankylosis happens congenitally, you will have to surgically remove and put a prosthesis. Prosthetic implant of the joint will be created. In congenital condylar ankylosis, surgically remove it and then give a implant of prosthesis joint. Okay, so joint prosthesis would be needed there in condylar ankylosis. And in coronoidal hyperplasia, again, you would refer to the oral surgeon for surgical management of the increased hyperplastic coronoid. So far, so good. Is everyone with me? Is everyone understanding the concepts that we are talking about? Now, does it give you an assessment of trismus? Why we are doing assessment of trismus? Because trismus comes for practically more than 20 reasons. If you don't assess it, you will not know which of the one of the 20 reasons is responsible for it. So to get that assessment and accurately understanding and determining the cause of trismus and what would be the effect on the patient and what should be the management, then you need to get a complete thorough history. You need to perform a full clinical examination, and sometimes you will be required to do your imaging as well, whether MRI or CT, depending on the disc problem, condylar problems, MRI versus CT. Right, for disc problems, MRI is better, but for condylar problems, condylar ankylosis, etc., CT would be better. Is that right or wrong? So imaging in some form would be required. Now, you will ask the patient also about the pain, right? Because other than other features which would be involved, and pain would also lead to some of the information about what can be the possible cause. So some causes of trismus will require urgent management. Can anyone, from the top of your head, you have all these causes here. Tell me which would require immediate urgent management. Your spreading odontogenic infections. Yes, immediate. And also we talked about that your tumors, head and neck. So if this trismus suggests that it's a malignancy, that also will require immediate management. Is that right? So spreading odontogenic infection, for example, or trismus, which is suggesting of a malignancy, will also require immediate urgent management. Agreed? But there are others as well, which is red flags. So let's talk about all the red flags which should alert you to refer the patient. Yes, Beatrice, of course. If it's an acute trauma, maxillofacial acute trauma, accidental injury, of course, that's an emergency patient only. That will not come to you, right? So it is very critical to establish in your patient who have been treated previously for head and neck cancer, so that this trismus that they present with is coming from radiation treatment or the cancer recurrence. Please write down on your notes. Whenever trismus in a history of patient and head and neck cancer, think about it. Is it coming from radiotherapy or is it coming from cancer recurrence? Because cancer recurrence requires urgent management. Okay? And sometimes trismus can in fact hinder your examination also. Isn't that right? Sometimes your trismus and patient's inability to open their mouth can also hinder your surveillance, your examination. So that is why if the underlying cause is previous head and neck cancer, please make sure to make urgent referral. Now, as you remember, red flags we have done in oral mucosal lesions. I will in the coming classes also take oral mucosal lesion classes. Why? Because they are also updated now in eTG. More than before conditions are given in eTG, I will be taking classes on that as well. So everyone remembers how well we have prepared the red flags from the third edition in our internal therapeutic guideline classes. Now there is another list of red flags that I want you to memorize. Yes, Beatrice, what I meant is, suppose you have a patient, he presents with trismus. When you take the history or see the records, you find there is a history of head and neck cancer, right? Which was treated with radiotherapy. Now, when you assess their trismus, there are certain features and findings which will tell you that whether this is a side effect of radiotherapy or this is a cancer recurring and hindering the movement. And that is an important understanding and learning on your behalf in your patient, that this reduced opening is either from radiotherapy or from the cancer recurrence, because it can become life threatening, right? If you ignore, if you think that it's radiotherapy side effect, but in fact it was a cancer recurrence, and you don't make a specialist referral, there is a risk of higher spread and even malignant spread of that cancer. Is that right, Beatrice? That is why the relationship has to be understood, that trismus either can be a radiotherapy side effect or can be a cancer recurrence. So do not just blindly follow that it's a radiotherapy side effect only. Understood, Beatrice and everyone else? Why this point has been very, very much highlighted in the TG also. So good question, Beatrice, but I want to see a big yes from you so you know what's the difference and you understand the concept now. So what are the red flags? Why the radiotherapy causes? So radiotherapy causes the atrophy of the muscles, right? In the radiation area, in the irradiation area, Beatrice. I'm assuming you wanted to know why it causes, right? So radiotherapy in the irradiated area leads to the atrophy of the muscles and mucosa, right? That leads to the reduced mouth opening. Now the red flags, everybody, let's talk about, yes, we are going to get to that point, Gifty. Okay. So let's talk about the red flags. Red flags is number one, that it is severe or persistent or worsening pain associated. Please, can you write down? It is severe. Tanveer, I'm going to be talking about the causes. So it's severe. The pain associated would be severe, persistent, or worsening kind of pain. So any severe pain or any worsening pain or any progressive pain is a red flag, number one. Then a progressively worsening trismus. Even trismus is progressing. That means earlier the opening was 25 and now maybe it is reduced to 20, then reduced to 15. So worsening trismus is also a red flag. Then severe local or systemic features of infections, which can compromise the patient's airway. So you know the severity and systemic features which are given in acute odontogenic infections chapter. Yes, the severity and systemic features, fever, right? Trismus, right? Involvement of mandibular spaces, floor of the mouth spaces. So Ludwig's angina associated spaces, right? Those are all your severity and systemic features of infection, which can compromise the patient's airway. That is also a red flag. Weakness in tongue or difficulty in swallowing is also a red flag. Firm, non-mobile, enlarged lymph nodes are also a red flag. Now tell me, firm, non-mobile, enlarged lymph node, what does that indicate? It's firm lymph node, immobile, fixated, and enlarged. That is a classic indicator of malignant tumor, right? So that means if there is no history of head and neck tumor, no history of radiotris, and there is a trismus with firm non-mobile enlarged lymph nodes, that can indicate an undiagnosed malignancy. Big yes or no? Wow moment or no? Bulb lit up or no? Tell me. So any patient presenting with tumor and you see these firm non-mobile enlarged lymph nodes, please let your all alarms go off, right? And then make referral to the specialist. Now, any past history of malignancy, that means trismus in a patient with a past history of malignancy, is also a red flag. And recent weight loss, again, tell me why weight loss? Again, an indicator of malignancy. Recent rapid weight loss associated with malignancies, yes or no? Weight loss, rapid weight loss, Priyanka, is a sign of Undiagnosed malignancy. Malignancy leads to rapid weight loss. Now there is another feature which suggests of red flag, which is giant cell arthritis. Right? Giant cell arthritis is, especially it is seen in older patients. There is a severe jaw pain which happens on chewing, but as soon as the chewing stops, the pain stops. That is a classic pathognomonic feature of giant cell arthritis. Inflammation in arteries, giant cell arthritis, classic feature, pain on chewing, settles immediately when chewing stops. There is also associated loss of vision or double vision, right? And there is a severe new onset headache and scalp tenderness. So it's acute in onset, giant cell arthritis, closely related to eyes, leads to loss of vision or double vision, and classic symptom is pain on chewing and stops upon stopping chewing. And a recent head and neck procedure, any surgery in head and neck procedure is also a red flag. If you have done a recent head and neck surgery and they develop trismus, will it be a red flag for you or not? If patient tells you only recently he underwent a head and neck surgery and few days later he presented with a trismus, would it not be a red flag? Tell me. Now, anything associated with hearing loss, new onset or even unilateral tinnitus or vertigo is also a red flag, because that can indicate, again, cranial nerve associated tumor. If trismus is also associated with hearing loss, unilateral, vertigo or tinnitus, it can indicate your cranial nerve associated tumor. Yes or no, please? If trismus comes with your hearing loss, tinnitus, or vertigo, that means auditory signs and symptoms. That means it could be a cranial nerve tumor. That is also a red flag. All these would require your urgent referrals. Understood? All the red flags are understood. Now let's talk about the management. You have understood the possible causes, which are the types acute and chronic. All the causes are understood. Acute causes and chronic causes, Monica. First of all, tell me, everyone, the causes are understood. Then assessment will be, take the patient history, whether it's acute or chronic, how long it has been. Is there any pain associated with it? Is there any difficulty in chewing or swallowing? If there is difficulty in swallowing, it's a red flag, right? Then systemic features, fever, weight loss, neurological symptoms. Are these red flags or not? Systemic and spreading symptoms, systemic and severe symptoms, red flag. Severe weight loss, red flag. Enlarged, firm, non-mobile lymph nodes, red flag. Past trauma, not so much, but a recent head and neck surgery, yes. Then examination will include, you will measure the interincisal distance and know for sure exactly how much the interincisal opening is. You will also palpate TMJ to rule out whether it's coming from the underlying joint causes or the masticatory muscle causes. Then you will look for swelling, asymmetry, and lymph nodes. Lymph nodes, why? Because it will help you if it's painful, mobile, and tender lymph nodes, that is associated with acute infection. Whereas it is a painless, firm, and your fixed enlarged lymph nodes, then it's from your malignancy. Then other investigations will include either your OPG, CT scans, MRIs, CT and MRIs, especially when you're suspecting any tumors or any TMJ pathology, right? Surgery can be causing various things. Surgery can be a post-op infection. Surgery can lead to improper healing. Surgery can also lead to a spreading infection, Nikita, right? Not a direct atrophy. Surgery most likely will be giving you acute reasons either from infection or delayed healing, right? Or some hematomas. Yes, MRI for the disc problem and CT for your condyle and glenoid fossa bone associated factors. Right, Priyanka? Wonderful. Now, what are the red flags? Red flags are rapidly progressing and severe pain, progressive worsening trismus, severe and systemic features of infections, difficulty in swallowing, firm non-mobile enlarged lymph nodes, and the past history of malignancy or a current suspicion like weight loss or firm nodes, and post radiotherapy fibrosis also. So if there is any history of recent head and neck procedure. Then giant cell arthritis. Everybody has understood the pathognomonic sign of giant cell arthritis. Arthritis. It is seen in older patients 50 years or above, and along with a severe headache, which is pain on chewing, stops with when the chewing stops, associated loss of vision or double vision, right? And a new onset type headache and scalp tenderness. Clear for everyone? CBCT is far more localized CT, Priyanka, so it has less exposure than CT scan. Okay, so it's cone beam CT, so it's lesser dose than your CT. So for dental use, CBCT is preferred over CT. Now, post radiotherapy fibrosis also. Okay, now let's talk about the management. I have given you a complete overview of the causes, the types, and the assessment factors. All are clear so far? The red flags, the examination, what to ask in the history, what imaging to be done, what are the types. Cranial nerve tumor can be given. So if your trismus, Bhumi, if your trismus is associated with vestibular symptoms, auditory symptoms, which is loss of hearing, then it could also indicate cranial nerve tumors on the base of the skull tumors, because that's where your auditory nerve is. And vertigo also, tinnitus also. Yes. Got that, Bhumi? Everybody understood? Now let's quickly talk about the management, and then we will practice one SBQ. So the approach to the management of trismus will depend upon its cause. You will not manage all the trismus same way. Underlying cause will decide your management. First of all, if you have a spreading odontogenic infection which has severe or systemic features, in that case, you will go and make an urgent management, which is the hospital admission. Is that correct or not? In case of your severe and systemic features present with your spreading infections, you require hospital management. So urgent management in those situations. For peritonsillar abscess, the management will be done for the peritonsillar abscess. If it is the cause is temporomandibular disorder, acute closed lock, then the management will come from there. You will send to the TMJ specialist, right? And even if a presentation is not an emergency, you will still find the underlying cause and then start the management. Now, if it's not an emergency cause without any red flag and it's a trismus, please know that the physiotherapy is the number one method or number one most helpful management tool for even your chronic closed lock or as an any adjunct for even rheumatological disorders. So any patient with scleroderma, systemic sclerosis, or your rheumatoid arthritis, for them, you will give them steroids and immune suppressive drugs. Yes or no? For any connective tissue disorders, you will give them steroids and immune suppressants. But as an adjunct therapy for those patients for trismus, you will give your physiotherapy. Even for your closed lock, Raj, physiotherapy and jaw manipulation, the disc manipulation is required. Surgery, no. Physiotherapy only. Raj, even in Odell we have done that. Physiotherapy, massages, hot and cold packs, they are your best management. Massaging, heat packs, active and passive stretching exercises. They are management for your acute or chronic close locks. Yes? So this increases the range of motion also. And it's a very helpful method and management plan to increase the mouth opening. Now, there are also something called as trismus devices, which are your stretching devices. Ivana, let me come to that. Right now, I have not given any medication, only physiotherapy, Ivana. That's your best management, okay? The medication that I talked about were steroids and immune suppressants, which were for the rheumatic conditions, rheumatological diseases. They are your autoimmune diseases. So, systemic management of those diseases require their own medications, immune suppressants, and corticosteroids. But they do not handle trismus. Trismus will be handled even in those patients by physiotherapy. Chronic closed jaw, physiotherapy. Acute closed jaw, joint maneuver plus physiotherapy. Clear for everyone or not? Rheumatological disorder, chronic closed lock, all require physiotherapy. Only for urgent causes, which is infection, peritonsillar abscess, trauma, hematoma, right? They may require referral to the specialist. Acute TMJ lock sometimes can also require arthroscopy or arthrocentesis, which is a surgical management. So some of the causes in which conservative is not working or has not been helping, in those situations, you could do surgical management. Okay. So even your acute TMJ lock, first management, there also you should do conservative therapy. But if it is not responding to the conservative treatment, then you would do arthroscopy. So even the conservative treatment is arthroscopy and arthrocentesis because they do not require complete joint opening. They are not complete radical surgeries. So for the first line surgical management in any internal disc derangements, you would do arthroscopy or arthrocentesis. Now in between these two, tell me which is a visual technique, which is a non-visual technique. Can anyone tell me arthroscopy versus arthrocentesis? Which is a visual technique and which is non-visual technique? Visual is arthroscopy. As the name says, there is a scope attached to it. So it gives you the visual of the joint content area. Whereas centesis is just joint aspiration and injecting drugs without visual aid. So that means which would be better if you are performing this minimal surgical management of internal derangement? Tell me which would be better, arthroscopy or arthrocentesis? Which would you prefer? In examination, you get this question that the doctor has suggested surgical management. Which should be the better approach for the management of internal derangement surgically? Arthroscopy or arthrocentesis? Absolutely correct. Answer would be arthroscopy because it is a facilitated technique through the visualization of the internal joint space. And by both the techniques, you're performing lysis and lavage of the joint space. And sometimes more radically, you can perform complete open surgery on the TMJ, but they will be done completely by the oral and maxillofacial surgeons, right? So that they will be done open techniques and open surgeries would be done for ankylosis of TMJ, where you would do complete resection of the condyle and put a joint prosthesis, TM joint prosthesis, right? And sometimes coronoid hyperplasia will also require open surgery. Give me now, everybody, I'm asking you the question. Give me the answer here. For which two reasons you will do open joint surgery? Coronoid hyperplasia and ankylosis of condyle. Coronoid hyperplasia and ankylosis of condyle. Now, there is a recent study of using muscle relaxants for trismus. Some recent suggestions that give muscle relaxants, baclofen and pregabalin. As per therapeutic guidelines, there is no evidence for such use that suggests or promotes. So, as per therapeutic guidelines, pharmacological management of trismus is not indicated. So, Ivana, your question is clear now? When you asked what drugs, what medications. So as per therapeutic guidelines, either your physiotherapy or surgical procedures Medications, no. Baclofen and pregabalin, Arshi. Baclofen and pregabalin. These are your muscle relaxants. They are not indicated. Baclofen and pregabalin here. Ivana, your question is also addressed. Beautiful. So sometimes pain management can be done with analgesics and anti-inflammatories and SAIDs, but not muscle relaxants. Right? And sometimes they say that if the patient is undergoing head and neck treatment like radiotherapy, and they say that you can do some therapies to prevent the treatment or trismus, no. Any preventive method cannot prevent the trismus associated with radiotherapy. Okay? So that is why if trismus happens after radiotherapy or any surgery of the tumor, only physiotherapy and sometimes the trismus devices. Trismus devices can sometimes be used along with physiotherapy, but they will only be recommended and should be done by the specialists only. Oral medicine specialists or oral maxillofacial surgeons. If you see here, this is one of the devices. It leads to stretching of the joint, but it can be extremely painful, and if it's not controlled, managed well, then it can lead to more harm than the benefit. That is why trismus devices are only done and should be recommended by experienced clinicians, and they are used as an adjunct to the physiotherapy only, not alone. So understood? Can you prevent? Now my question is, can you prevent the trismus from radiotherapy or surgery of the malignancy? Yes or no, please. Can you do any prehabilitation of the joint, of the muscles to prevent trismus? No. It is non-preventable, but if it happens, you manage it with, write down 2 things with which you manage after radiotherapy or after surgical removal of cancer, 2 methods by which you will manage it. Physiotherapy and trismus devices. Write down on chat so you finally remember it. Physiotherapy and trismus devices. Yes or no? So trismus devices are Therabyte, right? And physiotherapy. So this physiotherapy and devices, trismus devices, can be used for post radiotherapy. Okay? And surgery for what reasons? Can anyone remind me? Surgery. So for conservative surgeries, which is your arthroscopy and arthrocentesis, they are used for internal derangements. Conservative surgeries for disc derangements. And radical open joint surgeries for condylar ankylosis and coronoid hyperplasia. Beautiful. Understood or not now? Tell me. Easy peasy or not? So for your radiotherapy associated trismus, right, or surgery associated trismus, you use physiotherapy with trismus device. For your infections associated trismus, urgent referral for infection management. Yes, Sandeep, beautiful. Even for your hematoma, because it is auto-dissolving, you would do with your physiotherapy only. No need for even devices there, Sandeep. Yes, Centesis uses a lot of drugs. Botulin is one of the drugs, right? So Botox injections are being used, right? So there is an ADA policy on that also, Priyanka, which is covered in your hot notes about the use of Botox for TMJ. You'll get there. Now, what about progressive trismus? So progressive trismus usually should indicate underlying systemic condition like scleroderma, oral submucous fibrosis, and they would require specialist monitoring, right? And mostly oral medicine specialist. If that not, then oral and maxillofacial surgeon or dermatologist or ENT specialist. And you would tie up with a general medical practitioner and make sure that the patient gets the complete coordinated care. Post-radiotherapy and surgery trismus management, physiotherapy with, so post-radiotherapy and surgery, the trismus is managed with physiotherapy as well as trismus devices. Infection associated with require urgent referral for infection management. And your coronoid hyperplasia and your ankylosis of condyle will require open joint surgeries, as well as internal derangements of the disc will require conservative surgeries like your arthroscopy or arthrocentesis. Right, Suyesh? I'm adding on more to that. Beautiful. All summarized or not? Tell me, tell me, tell me. Everything learned, understood. So think about it. The causes are understood, assessment is understood, and the procedures, the physiotherapy management, which is the conservative management, as well as the surgical management, arthroscopy and arthrocentesis for acute closed lock, complete coronoidectomy, which is open joint surgery for coronoid hyperplasia, right? So yes, here, coronoid hyperplasia and condylar ankylosis will require open joint surgery, okay? And the prosthetic replacement of the joint. Got it? So much clear? Beautiful. So what are the key updates in eTG? They gave you the complete assessment. They gave you the complete management, the multidisciplinary approach. Now tell me, will you look at the trismus and just think of TMD? Tell me now, everybody. Will you look at a trismus and just think of TM joint problem, or 20 other problems will now immediately show up? And you are now experts, my dear, to handle any trismus in your patient, and you can get to the root of any trismus, and you will know the management of any etiological factor for trismus. Yes or no's? So you do not use muscle relaxants, right? And you cannot do prehabilitation, and you have physiotherapy management, trismus device management, conservative surgery management, open joint surgery management, right? So trismus is a restricted mouth opening caused by multiple factors. Management can include various conservative and radical approaches: physiotherapy, trismus devices, arthroscopy, arthrocentesis, open joint surgery, but no muscle relaxants. This derangement, yes. Arthroscopy, yes. Ankylosis, open joint surgery, yes. And prosthetic joint replacement, absolutely yes. Coronoid hyperplasia, also open joint surgery, so yes, beautiful. But in coronoid, when you do the coronoidectomy, you don't require the joint prosthesis because that's not the joint, so yes, right? You just reduce the size of coronoid, that's enough. But that would require an open joint surgery. And we, for internal joint derangement, arthroscopy. Arthroscopy is better than arthrocentesis, Tanveer. Clear for everyone? So always know the red flags. They will be key for your ADC exam. Physiotherapy is the mainstay. You will not advise muscle relaxants. They are your takeaway points. Now, we are practicing one SBQ here, and after the lecture, I will post another question to practice. So make sure you attempt all the questions and test your knowledge right away. Lida is a 52-year-old woman presenting with worsening difficulty in opening her mouth over the 4 months. Tell me, more than 6 weeks, acute or chronic? Tell me, I'll ask more questions also other than the main question so that you can immediately reiterate all the concepts. Okay, so she reports jaw pain, classic sign. So pain is a symptom. Pain is a also red flag. Stiffness in the mornings, very specific trismus symptom, right? And occasional dysphagia, difficulty in chewing and eating. On examination, interincisal distance is 22 mm, which is quite low, significant reduced MIO, max, right? Incisal opening, maximum incisal opening 22 is significantly reduced here. Patient has thickened oral mucosa, pallor of the tongue, taut shiny skin on her hands. ESR is mildly elevated. Anti-nuclear antibody is positive. So it's an autoimmune disease? Yes or no? With the antibodies positive. So yes, Autoimmune diseases are linked with the trismus or not? So Priyanka, will you think of bruxism because of the stiffness and all that? No, now, na? Because there is a positive history of antibodies, ESR, so it is not the MPDS now, not bruxism, not MPDS. That is why you don't see trismus and jump to TMD. Number one concept application or not, you don't see trismus and don't jump to TMD. See, there are antibodies. See, she has a shiny taut skin on her hands. She has thickened oral mucosa. So it can be oral submucous fibrosis. But oral submucous fibrosis doesn't have taut, shiny hand skin. So that means systemically the condition is involved. Right? That means OSMF is also ruled out. So hand skin is involved. Antibodies are involved. Scleroderma, systemic sclerosis. Yes or no? Beautiful. Wonderful, Henna. So that means you don't look at trismus and don't jump to TMD. Now, easily if somebody puts the option of which single feature differentiates this case from the trismus caused by radiation fibrosis or chronic TMD. Because everybody wants to jump to chronic TMD, bruxism, MPDS. What is helping you differentiate that no, this is not chronic TMD? Is it morning stiffness? Well, that would be with any trismus. Morning stiffness would be also with chronic TMD. Morning stiffness will also be with radiation, but will not. It will also be with your connective tissue disorders. So it is not a specific. It is not a pathognomonic sign, right? So is ruled out. Interincisal distance reduced to 20 mm, 22 mm can also be seen with various causes, not a specific cause. Mildly elevated ESR. Now, ESR can be elevated because of any inflammation in the body. It's not a very pathognomonic sign. Is it a specific test? ESR is practically elevated in every kind of fever. Even your low-grade fevers would have an elevated ESR. Is it a classic pathognomonic sign? It just indicates inflammation. Dysphagia also can be associated with radiation fibrosis, right? So not a classic sign, but the shiny taut skin changes of the hands is not seen in chronic TMD, is not seen in radiation fibrosis. The TMD and radiation associated are only seen in mouth. So B, hand involvement. What is ESR? Is erythrocytic sedimentation rate, Beatrice. It's a blood test, erythrocytic sedimentation rate. So faster ESR means there is higher ESR indicates inflammation in the body. It's a non-specific test to indicate inflammation. Okay, Beatrice? Beautiful. Now tell me, everybody, answer B is understood. Tanveer, I got your answer beautifully correct. So what are the cases in which ESR is associated? Where the ESR is coming from the systemic autoimmune diseases, ESR will be elevated, Gifty, right? Even your odontogenic infections would have elevated ESRs. Odontogenic infections, pericoronitis, all those inflammatory conditions will have elevated ESRs. It's a non-specific cause associated with trismus, right? Gifty, good question. I hope you got your answer. Any infection, any inflammatory condition will lead to that. Now, if this patient's conditions progresses, which mechanism most directly explains her worsening trismus? I just told you a few minutes back, progressing trismus indicates a progressing systemic disease. So if this patient's condition is progressing, which mechanism most directly indicates? Will the trismus increase and worsen because of fibrotic changes in TMJ capsule? Tell me. Or chronic non-reducing disc displacement. Will her systemic condition lead to disc derangement? No, right? And radiation, so the fibrotic changes in the joint after radiotherapy, again ruled out because in her case, radiotherapy is no needed. Submucosal deposition of collagen leading to hypomobility. Isn't that the cause of systemic scleroderma, systemic sclerosis? Yes or no? And it is not autoimmune erosion of mandibular condyle cartilage, because where is the erosion of the condyle seen? Tell me, tell me, tell me. Which autoimmune condition leads to the erosion of the mandible condyle? Beautiful. One answer. One word. No, two-word answer. Give me one condition. Erosion of condyle in an autoimmune condition. Rheumatoid arthritis. Beautiful. Not her condition. Wonderful. It would be seen in rheumatoid arthritis, but not in systemic sclerosis. So fibrosis of lateral pterygoid. Does your systemic sclerosis lead to fibrosis of lateral pterygoid muscle? No. It leads to submucosal hypercollagen deposition, which leads to hypomobility in joints. Right? So C is the correct answer. Everybody got it or not? Now, which red flag feature, if it happens in this patient, will suggest that there is an alternative diagnosis like giant cell arthritis rather than the scleroderma or systemic sclerosis? That means which symptom would indicate giant cell arthritis? Give me the answers. Now you know everything. So interincisal distance reducing progressively, that could be with anything. Not specifically for giant cell arthritis. Jaw pain during chewing that stops immediately after chewing, that is a pathognomonic feature. It's a very, very specific pathognomonic clue. Dysphagia again could be with any condition. Positive antibodies is not seen with giant cell arthritis. Antibodies are seen with autoimmune conditions. Skin tightening with Raynaud's is also not feature of scleroderma, right? Sorry, not feature of giant cell arthritis, but scleroderma. So that is also ruled out. So option E is a classical systemic sclerosis symptom, Raynaud's and skin tightening, shiny taut skin with Raynaud's phenomena. Any other condition where Raynaud's phenomena is seen, autoimmune condition? Give me, give me, give me. Again, ADC relevant question. Any other autoimmune condition where Raynaud's phenomena is seen other than systemic sclerosis? Absolutely correct. Secondary Sjogren's, right? Where other connective tissue disorders are also seen, Ramona. Beautiful. Priyanka, autoimmune diseases. This is a perfect place to learn about it in exam. Systemic sclerosis, Sjogren's. So you have been doing Sjogren's and exam has been asking Sjogren's or not? Tell me, everybody tell me. Sjogren's exam has been asking or not? Related to dry mouth or not? Rheumatoid arthritis exam has been asking or not? Rheumatoid arthritis exam has been asking or not? Another autoimmune disease. Now tell me, did you not learn about the third autoimmune disease today, which is systemic sclerosis or scleroderma? Tight, taut, shiny muscles, trismus associated, right? I'm saying, Gifty, that for ADC, you have been preparing Sjogren's, you have been preparing rheumatoid arthritis. The third orally important autoimmune condition is systemic sclerosis or scleroderma, which gives you a classical trismus, which you have to identify, assess, and manage. Right? So now 3 autoimmune, Priyanka. Earlier you knew 2, no? Now you know 3. Is it not better to know 3 than 2? Tell me. Is it not good to know 3 autoimmune conditions than 2? Does that not make you more knowledgeable, my girl? Tell me. Yes, it does. So own it with confidence. And one more revision and you are absolutely never going to forget it. No, GCA is an inflammatory condition, Nikita. GCA is an inflammatory condition, not autoimmune. Now in this patient, Which management strategy has the strongest evidence base for maintaining oral function long term? So for any connective tissue, muscle relaxants or surgery? Do you do surgery? No. For surgery, we do conservative surgeries for internal disc derangement, radical surgeries for ankylosis or coronoid hyperplasia. Yes or no, please tell me. Everybody. Yes or no? Tell me, even on Facebook, people tell me, Tanveer, you have been asking about the surgeries. Suyesh, you have been asking about surgeries. So tell me now. No need for surgery here, no? Because for surgery, conservative surgeries in internal disc derangements and radical open joint surgeries for your ankylosis and coronoid hyperplasia. So can you all hear me now? Is it working? Is the connection back? Yes, beautiful. Even on the Facebook, the connection's back, right? Okay. So now the last question, which management therapy would you use for the management of systemic sclerosis related trismus? So tell me, is the immune suppressive therapy or steroid therapy or muscle relaxant will target your trismus associated with an autoimmune condition? Tell me, yes or no's. Will the immune suppressive, steroids, or your muscle relaxants be indicated? No. Immune suppressive and steroids will be indicated, but not for your trismus, but for the management of autoimmune disease. Early surgical intervention also not. Tanveer, my question was to you. You now understand the surgical interventions indications, right? Conservative arthroscopy and arthrocentesis, as well as your open joint surgeries also. Everyone present, you know the surgical indications or not? So in exam, if the variation comes, you will know where to choose the surgical interventions. So not here again. Here you will use regular physiotherapy with trismus devices, jaw stretching devices. And that is it for today. Thank you so much for your attention, so much for your participation, so much for reception. This class will be uploaded on the app, Bilal. I hope you loved today's class. I love talking about it. I loved breaking it down and explaining it to you. And I hope now nobody just sees trismus and thinks about spreading infection or TMD. There is so much under the iceberg, and you have gone and dived and seen the below the surface of the iceberg as well. Yes or no's? So we did a good sea diving here and went under the iceberg and really saw how big it is. And it's not just your TMD and not just your infections. Priyanka, I love this dissection. So that is why next week we are going to meet again and we are going to do more on TMD or bruxism, or we are going to do something upon bronch, which is also new. Then we could do something on oral mucosal diseases, which is new. I'm so excited to do everything new with you. Why? Can anyone tell why I am so excited to do all these things with you? More than you. Tell me, Nikita, still confused? Don't tell me you're still confused. That is so good, SNADC. Now you know that there could be so many concepts. Nikita, watch this class again, and hot notes will be given. No, Gifty, not because ma'am learns teaching. I am more excited than you because I love more learning. I love to learn with you, not teach. So that is why I am excited more than you are because I will be learning with you, right? So the good teacher is one who teaches most, or a good teacher is the one who learns the most. Medical diseases, Beatrice, I have done 3-part series on medical conditions. Have you seen that on app? Beatrice, they are on the app, 3-part series, and everyone raves about it. Trust me, you go watch them. The medical emergencies, 3 parts, and medical conditions, 3 parts. They are our, what can you say, top rated videos. All right. So just watch those and you will love those chapters. Hot notes of anxiety will be released in the next 2 or 3 days, Tanveer. Hot notes of trismus will be released by next Tuesday or Wednesday. And then probably next week, we will do another important ETG update. All right. Thank you so much. I had so much fun and I hope you guys had fun too. I thought we'll cover it in 1 hour, but we spent 2 hours together. See, time flies and we just don't realize. I'll post one more question on Facebook. We'll publish the link on the WhatsApp group. Please stay in 5 minutes. I'm going to post that question. Post the link. Do not sleep yet until you solve one more question. Okay? All right. Thank you so much, guys. Bye-bye. See you soon. Bye. Yes, and probably Mubaraka before that result may come. So we might be meeting for celebration. So let's just hope. And anybody who's here who took the exam in September, all the best to you. Please stay calm. I know it's easier said than done. And I know your nerves are all fired up. Just maybe, watch an actual Netflix rather than you have watched last 5 months the, ADC Netflix. So probably go watch the actual Netflix for a while till the results come out. And yeah, everything will be good. Everything will be amazing. Keep trusting. And probably if the results come out, we'll meet again for celebratory reasons. And if the results come next week, then I'll see you for an academic class next week then. All right? All right, bye-bye. Thank you. And I'm going to post the question now. Do not move. Stay, check your Facebook, answer the question, and then sleep. All right? Okay, bye-bye. Bye. Bye, Priyanka. Bye, everyone. Thank you. Bye.